In this chapter, let's learn about insulin therapy of diabetes. In 1921, Banting and Best found that a dog with the pancreas removed showed typical symptoms of diabetes. When the dog was injected with the extract, the dog recovered from a coma within a few hours. The dog's urine returned to no sugar, and the blood sugar was also reduced to a normal level. When the injection of extracts stops, the symptoms of diabetes reappear. Subsequently, the good effects of insulin on the treatment of diabetes was further affirmed in diabetic patients. At this point, diabetes, which once brought people to death, has finally been overcome. The available formulations largely differ in their pharmacokinetics, as shown in table. Insulin lispro, insulin aspart, and insulin glucagon are rapid-acting insulin analogs that have an onset of action of 5 to 15 minutes, peak activity in approximately 1 hour, and the duration of activity of approximately 4 hours. Regular insulin is approximately half as fast as the rapid-acting analogs, with onset in 30 minutes, a peak at 2 to 4 hours, and the duration of action of 6 to 8 hours or longer. Regular human insulin, when administered intravenously, is instantly effective, with a half-life on the order of 10 minutes. NPH is the only intermediate-acting insulin available since Lantus insulin was withdrawn from the market. Onset, peak, and duration are about twofold greater than those of regular insulin, with an onset of action in 1 to 2 hours, a peak at 4 to 8 hours, and a duration of action of 12 to 16 hours. Ultra-lengthy insulin is no longer available as human long-acting insulin. Insulin glargine is a long-acting insulin analog that is solubilized in acid, but precipitates when neutralized in tissues on injection, producing no consistent or distinctive peak in activity and a duration of action of more than 24 hours in most patients. Insulin detamers is a long-acting analog in which a fatty acid side chain has been covalently bound to the insulin molecule. It remains soluble both in the well and in the tissues, and has a duration of action of about 24 hours, except at low doses. Premixed insulin formulations provide greater convenience and accuracy of mixing than those mixed by patients, but at the expense of reduced flexibility. Premixed formulations available are 70-30 and 50-50 mixtures of NPH and regular insulin. A 75-25 and a 50-50 mixture of lispro insulin in its NPH-like formulation with insulin lispro, and a 70-30 mixture of insulin aspart with its NPH-like congener. Premixed insulin generally provides a profile of activity as expected from the addition of the activities of its components. Adverse events associated with insulin are well known and include weight gain and hypoglycemia. Both fast-acting and long-acting insulin analogs have been shown to provide a modest reduction in hypoglycemia. Insulin allergies are rare, as are chronic skin reactions, which include lipodystrophy and lipohypertrophy. The absolute risk of severe hypoglycemia in patients with type 2 diabetes is relatively small, approximately 1/3 to 1/10 as high as in similarly treated patients with type 1 diabetes. This risk can be further minimized with appropriate education of patients and expanded home glucose monitoring at times when unrecognized hypoglycemia is most likely to occur. Newer insulin needles causes less discomfort than those previously available because of a finger gauge, shorter lengths, sharper points, and smoother surfaces. Insulin pen technology makes teaching a patient to take insulin much easier and provides greater convenience and accuracy of dosing. Insulin pump therapy has been used in patients with type 1 diabetes and some type 2 diabetes, but is not widely accepted as cost-effective in routine use. Indications for insulin include type 1 diabetes. Patients with type 1 need insulin substitution therapy, basal insulin combined with prandial insulin therapy. The patients who combined with severe acute complications and severe chronic complications need insulin therapy. By diets and oral medications not yet being well-controlled patients consider starting insulin therapy. Diabetes patients in a special period need insulin therapy, such as perioperative, pregnancy, childbirth. For newly diagnosed type 2 diabetes patients with severe hypoglycemia, we can use short-term intensive insulin therapy to relieve high glucose toxicity and allow pancreatic islet cells to rest. For other patients, for example, weight loss in patients with type 2 diabetes, patients with some other special types of diabetes, insulin therapy may also be considered. If fasting blood glucose rises during the use of insulin, it is necessary to identify the cause of the fasting glucose increase and take different measures to improve fasting glucose. We usually measure blood glucose at 0 o'clock and 3 o'clock at night to observe the blood glucose situation at night. If the night blood sugar is high and the fasting blood sugar is also high, which is insufficient nocturnal insulin action, and the basal insulin dosage needs to be increased. If there is a nocturnal hypoglycemia and the fasting blood glucose rises, this belongs to Somogyi effect. It is necessary to reduce the amount of night insulin to correct hypoglycemia. If the blood sugar is normal at night, but the fasting glucose is elevated, this is a dawn phenomenon. This situation can increase the amount of nighttime insulin or use metformin to improve fasting glucose. Next, we use the flow chart of the guideline to summarize the hypoglycemic treatment of diabetes. The ADA management of hypoglycemia in type 2 diabetes recommend a patient-centered approach to choosing appropriate pharmacologic treatment of blood glucose. This includes consideration of efficacy and key patient factors. The first, important comorbidities such as ASCVD and indicators of ASCVD risk, chronic kidney disease and heart failure. The second, hypoglycemia risk. The third, effects on body weight. The fourth, side effects. The fifth, cost. And the sixth, patient preferences. Lifestyle modification that improve health should be emphasized along with any pharmacologic therapy. Metformin should be started at the time of type 2 diabetes is diagnosed unless there are contraindications. For many patients, this will be monotherapy in combination with lifestyle modifications. Metformin is effective and safe, is inexpensive, and may reduce risks of cardiovascular events. Because type 2 diabetes is a progressive disease in many patients, maintenance of glycemic targets with monotherapy is often possible for only a few years, after which combination therapy is necessary. If the A1C target is not achieved after approximately 3 months, metformin can be combined with any one of the preferred 6 treatment options. sulfonylurea, TZDs, DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 receptor agonist, or basal insulin. The choice of which agent to add is based on drug-specific effects and patient's factors. For patients with established ASCVD or indicators of high ASCVD risk, established kidney disease or heart failure, an SGLT2 inhibitor or GLP-1 receptor agonists with demonstrated CVD benefits is recommended as part of the glucose lowering regimen, independent of A1C and in consideration of patient-specific factors. For patients without established ASCVD, indicators of high ASCVD risk, heart failure, or CKD, the choice of a second agent to add to the metformin is not yet guided by empiric evidence. Rather, drug choice is based on avoidance of side effects, particularly hypoglycemia and weight gain, cost and patient preferences. Okay, in this chapter, we have learned insulin therapy of diabetes. Thank you very much.